Hi, everyone. My name is Nora Bennani. I am a faculty within the Division of Hematology with the Lymphoma group. It is my pleasure today to talk to you about a new diagnosis of T-cell lymphomas. And the way I will structure this is basically how I talk through a new diagnosis with one of my patients when I see them in the clinic. So we have a diagnosis, we are ready to treat. We've taken things into consideration as I mentioned earlier. Normally, the T-cell lymphomas are aggressive, and we tend to treat them with combination chemotherapies. You are going to hear things like CHOP, CHOP or CHOEP. Those are letters that each letter means a different type of chemotherapy. And the goal of treatment is, to get rid of the lymphoma, get rid of the disease, improve the symptoms, shrink the lymph nodes, and the hope is that we get a cure potentially. Okay, that's the goal. In general, we will start chemotherapy, the combination chemotherapy drugs. We will give 2 to 3 cycles, and then we will repeat the PET scan to assess for response. We want to make sure that this disease is responsive to the chemotherapy that we are given. And most of the time, after 2 to 3 cycles, we will see improvement in disease, meaning the areas that were lighting up on the PET scan are mostly gone or gone, and the tumors have shrank significantly. Okay. You are going to hear some words for response. So response to therapy, you're going to hear complete response. So this is when the disease is entirely gone based on the PET scan. Partial response, when some of the areas that were involved are gone, but some remain enlarged or lighten up still. You may hear stable disease when there is not much of a change. And you may hear progression of disease when there are new areas that pop up after treatments. And the goal in general, we want to see complete response as much as possible. Okay, so we decide on the type of the chemotherapy based on the subtype that you have. And I'm going to mostly talk about the most common subtypes, which are the nodal PTCL, and these include angioimmunoblastic T-cell lymphoma, which is one subtype of the nodal PTCL. There is the anaplastic large cell lymphoma, and there is the ALK positive and the ALK negative. There are the PTCL NOS, which are a bunch of T-cell lymphomas that we put together because we just don't know more about these. So we often look at tumor markers. When the pathologist gives us a report, we look for certain keywords. And one of these is a tumor marker that we call CD30. The reason we look at that, if the disease is CD30 positive, it will tell us that we could potentially use a somewhat recently now, FDA-approved drug, which is called brentuximab vedotin. This drug targets CD30, which can be expressed on the surface of the tumor. So when the tumor expresses CD30, we may add this new drug. In short, it is called BV, brentuximab vedotin, BV. If the disease is CD30 negative, we are not going to add it because they're unlikely for it to be beneficial. Typically, we will treat with this combination chemotherapy, CHOP or CHOEP for CD30 negative disease. If CD30 positive disease, we are going to treat with BV, CHIP. We will remove one drug because when that drug is combined with BV, there is higher risk of nerve toxicity. So we, in general, will give a cycle, which is 1 day of IV chemotherapy, 5 days of prednisone, which is oral, and that you can take at home. Most of the time, we're going to treat in the outpatient setting, meaning you're going to go to the chemo suite. However, sometimes when the patients are very sick or they have high tumor burden and we worry about when the disease starts melting down, there is high risk for kidney dysfunction, abnormal electrolytes, and all of that, then we will admit the patient to the hospital just to get them through the first cycle safely. And then for the future cycles, then they can get their treatments at home. Okay? All right. So we are going to give a cycle. One cycle is day 1, and that repeats every 3 weeks or 21 days. Okay? In general, we will give, depending on the stage, but most of the time we're going to be looking at 6 cycles. So 1 cycle every 3 weeks times 6 times. We will repeat, as I mentioned before, a PET scan after 2 to 3 cycles, and then we will have another PET scan at the end after the 6th cycle to confirm that there is no disease, that the patient is in complete response. Most of the time, but not all the time, so most of the time we will think about consolidation with autologous stem cell transplant, high-dose chemotherapy and autologous stem cell transplant. Even if the disease is gone, sometimes you may have still residual disease that we cannot see with the naked eye on the PET scan. The way I mention it to my patients is like you have a dandelion or a weed. You remove the weed, you're gonna leave the roots under, in the ground that you cannot see. Within a week or 2, that the weed is gonna grow back. So you want to remove the roots. So those the tumor cells that are hidden. We need to get rid of those to make sure that response is maintained. So we tend to give additional high-dose chemotherapy to get rid of those hidden tumor cells. And we will give stem cells, your own stem cells back to replenish your bone marrow, and so you are not transfusion dependent. And that's a whole process that we do education about. Okay? In some rare diseases that are more aggressive, we may be talking about the donor stem cells or allogeneic stem cell transplants. T-cell lymphomas, some of them can be more challenging to treat and not respond as well to chemotherapy as we want them to. And that's why we treat this aggressively. So this is pretty much how we manage newly diagnosed T-cell lymphomas. We do a lot of education along the line. I would like to emphasize this one thing before I end this discussion, is that we want our patients to be treated on clinical trials. Although we do have good therapies that we treat as part of standard of care, we always emphasize if there is a clinical trial that you are eligible for, go for it, because the clinical trials will provide you with something extra that could potentially be more beneficial to treat your disease than the standard of care. So whenever you see your provider, whichever center you end up at, inquire about clinical trials, and your provider will talk to you about the possibilities of clinical trials. Okay. Many of these drugs that are available to you came to FDA approval through clinical trials, and they showed the benefits. So, for example, this BV I was telling you about, brentuximab vedotin, it was through a large clinical trial that was done. And because these diseases are rare, the clinical trials are most of the time that lead to FDA approval are relatively small. So the number of patients is relatively small, but we keep that in mind. So we do have a clinical trial that is available to our patients who have a new diagnosis of T-cell lymphoma when the disease is CD30 positive. This is a national clinical trial. And there may be others down the road. Okay, I hope that I managed to demystify a little bit and explain what this diagnosis means, how we go about it, and the hope at the end is possible cure. Okay. I'm happy to answer any question. Feel free to reach out to me. My name is Nora Bennani. I am one of the faculty members within the Division of Hematology at Mayo Clinic, Rochester. Thank you for listening.
I want to express our sincere thank you to our patients, to the members of our Mayo Clinic Lymphoma Disease-Oriented Group, to the Mayo Clinic, and to the Goldman Philanthropic Partnerships for this generous gift to produce this series. This gift has an incredible duality in that it goes directly toward enhancing patient care and provider education. We are at a time of phenomenal rapid change in the treatment plans, the biology, and approaches to clinical care in patients with lymphoproliferative disorders. This project will serve to inform. Again, our sincere thank you, and in the words of Dr. William Mayo, quote, "The needs of the patient come first."